Hi, Tapka CM. Thank you very much. I have a disclosure to make. I may be head of thought leadership. My wife's title is Supreme Galactic Empress. So, due humility. How do we respond to the huge challenges which Adrian outlined in providing health and care for our communities? And these challenges are just enormous in all of our countries around the world. But what strikes me most forcibly when we look at this context is that we are damaging the health and well-being of the people we ask to deliver high-quality health care for people in our communities. We're damaging the health and well-being of the people who deliver health care. When you look at the culture and engagement surveys in British Columbia, you see that's the case. In England, in the National Health Service, 1.4 million people, 50% more staff in the NHS report debilitating levels of work stress compared with the general working population as a whole. Every year, 40% of staff in our system report being unwell as a result of work stress during the previous year. And that's replicated across different countries. And it's important because it's damaging the lives of people who deliver health care. But it also affects the quality of health care that we provide. It affects error rates. It affects our ability to be compassionate. And in the acute sector, in hospitals, we know that it's associated with higher levels of avoidable patient mortality. So what are we to do? There are various national initiatives. You hear from your provincial government and from different national governments, national initiatives that focus on our health and care systems. Often they're very worthy initiatives, very important, but for the most part they don't get to the core cultural problems, which I think underpin some of these issues to do with staff stress and poor health and well-being. So what are we to do? I think we have to go back to the core of what our healthcare systems are all about. When public health was introduced in Canada, it was with a commitment to providing free care to all those who needed it, regardless of health, wealth, background. And in our National Health Service in England, we introduced a system in 1948 designed to be inclusive. And I think it manifested a core national value of compassion, that post-war society wanted to create a compassionate and inclusive system. And we've been fiercely protective of it ever since, because it's such a core societal value for us, I think, as it is for you here in British Columbia also. And all of you and all of the people who you work with made a decision at some point to dedicate an enormous part of your unique, precious, mysterious, magical lives to caring for your fellow people, to caring for your communities. So you too, and all of those you work with, embody that core work value of compassion. Compassion for me is the healthcare assistant, the very junior healthcare assistant I saw who sat for an hour after her shift had ended, holding the hand of an elderly lady who was in distress and speaking with her lovingly and caringly until she was calm again. It was a general practitioner in South London who told me recently that she danced in her surgery that day with an elderly, lonely man when she discovered they had a shared interest in dancing. Beautiful. And I'm sure you see and embody acts of compassion like that every day. But let's probe a little deeper. What is compassion? If Lynn here, forgive me Lynn, is in distress, then for me to be compassionate, I first of all have to be present with you. I have to be here and now with you. I find Nancy Klein's wonderful phrase, listening with fascination to you, really helpful as a way of embodying that. And second is I have to understand what the causes of your distress are. And ideally, we do that through a dialogue. And third is I have to empathize with you. I have to feel your distress at some level, because that gives me the motivation for the fourth step, which is asking, how can I serve? How can I help you with your distress? So attending, understanding, empathizing, and helping or serving. Does that make sense? Those four elements of compassion? Does that make sense to you? And we know that when healthcare staff are able to provide compassionate care, that patient service users are much more satisfied with the care they receive. And that in turn has an effect on the well-being and the commitment of staff. So we get virtuous cycles of compassion. And the challenge for us, therefore, is how can we create the conditions where staff can deliver the high-quality, compassionate care they wish to deliver. And that's about how we can create cultures of compassion, cultures the most powerful influence on our behavior in workplaces. And every interaction by every one of us every day shapes the culture of our organizations. How civil we are, how kind we are, how humorous we are, how irritable we are, all shapes the culture of our organizations. But the role of leaders is particularly powerful. What leaders pay attention to, what they monitor, what they talk about, what they reward, what they model in their behavior, tells us what they value, and values what we value. Not the words on the website. What we value in practice is the culture of our organization. So in order to create compassionate cultures in healthcare, our leaders have to embody compassion in their leadership. That means leaders who pay attention to those they lead, who listen to them with fascination. One of the most common complaints I hear from health and care staff is, we only ever see our senior leaders when something goes wrong. Second, it's about leaders understanding the challenges those they lead face. And ideally that happens through a dialogue, so that it's both a more accurate and a shared understanding. And third, it's leaders empathizing with those they lead, feeling for them. Given what we know about the levels of stress for health and care staff, our leaders should be empathizing without being overwhelmed by feelings, because that gives the motivation for the fourth step, which is asking the question, how can I serve? How can I help you? Another complaint I hear from health and care staff is, actually, some of our leaders are really good at coming around and talking to us. They're really good at listening. But then nothing ever changes. So in order to create cultures of compassion, we need leaders to embody these four behaviors in their leadership. And in England, the national bodies that oversee the National Health Service, 1.4 million staff, have sponsored a new framework, a leadership development and improvement framework, which has at its core a commitment to developing collective, compassionate, and effective leadership at all levels of our system, from the Secretary of State down to the frontline supervisor, and a commitment to developing improvement methods so that all staff are equipped to do the kind of quality improvement that the minister was referring to. And those national bodies have also pledged that they will commit to changing their cultures so that they embody the compassionate and collective leadership which they're prescribing for the rest of the system. And to model those collective and compassionate leadership behaviors in their dealings with the organizations that provide health and care. And that approach is also being adopted by other countries now, by Northern Ireland and elsewhere, because of a recognition, I think, of the centrality of compassion to cultures that deliver health and care. We've also been able to identify through research over the last 20, 30 years, the key cultural elements that really make a difference to the performance of organizations of health and care organizations around the world. And if we know what those key cultural elements are, that tells us what we as leaders should be focusing on. There's so much stuff that comes at us as leaders in health and care, but the research evidence tells us that these 5 areas are absolutely critical in organizations around the world that consistently deliver high-quality health and care. I want to describe them briefly to you. The first is a vision that's focused on providing high-quality, continually improving, and compassionate care. And this can't just be a bunch of words on the website. It's about ensuring that that vision is embodied by leaders at every level, every day. If it's simply a bunch of words on the website, but what people in the organization see is inconsistent in terms of leadership behaviors with those messages about the vision of the organization, that corrodes trust, it corrodes commitment, it corrodes engagement. And that means that we need to be vigilant about making sure, both at provincial level and at national level, that our leaders are not spending more time talking about financial performance, productivity, than they are about high-quality care for people in our communities. Because otherwise the message goes out that what our leaders value above high-quality care is financial performance, and that's a slippery slope. The second is the importance of making sure that we translate visions in our organizations into really clear priorities. So what we see in health and care organizations is that there are all sorts of groups and leaders who are setting priorities. Your minister sets priorities. Your board set priorities. Your departments and directorates set priorities. And we've come to call them in our research team the priority thickets, because there are so many priorities, we can't see clearly what's important anymore. And people are overwhelmed at the front line. We also know from the last 60 years of research on human motivation and performance at work, Gary Latham from Canada, one of the leaders in the world in this area, that people's motivation and performance is highest when they have agreed a limited number of clear, challenging goals aligned to the vision for their work. And we also know from 30 years of research on healthcare teams that the most important determinant of the effectiveness of healthcare teams is whether they have agreed, rather banal conclusion, whether they've agreed a limited number, 5 or 6, of really clear, challenging objectives for their work. So what's really important in our organizations in terms of culture is that as leaders, we make sure that there is alignment of people's efforts towards that vision, them having agreed a limited number of clear priorities at every level, beginning with the top management team in organizations and going down to every team within the organization as a whole. And there's some examples there of the kind of dimensions we could consider as being part of health and care teams' objectives. One of the objectives of every team should always be improving the effectiveness with which we work with other teams in our organization or outside our organization to ensure high-quality, compassionate care for people in our communities. The third principle is the importance of people management, and that's about leadership. And what we know about good leadership is that we need leaders who are authentic, genuine in the way that they interact with those they lead. Leaders who are open and honest wherever possible. Leaders who display the characteristic of humility, which we know is linked to high-quality leadership. So leaders who are always asking, how can I lead you better? What do I need to do more of? What should I do less of? How can I be a better leader for you? Because none of us is the finished product as a leader. Leaders who are optimistic, leaders who are compassionate, and leaders who are appreciative. The single most common complaint I and my colleagues hear from health and care staff is, apart from patients, service users, no one ever comes and says thank you to us. And yet saying thank you, appreciating people's contribution, sends ripples through a kind of emotional contagion through our teams and organizations. Unless you think this is simply ideology, we've been gathering data for the last 14 years from a national staff survey in England that's completed by 250,000 NHS staff every year. And what that survey has enabled us to do is to identify how working in healthcare is changing from the perspective of staff over time. And we've seen that the percentage of people reporting having an appraisal has gone up from 66% from 66% to 86% over that period. The percentage of people who say it's been a helpful conversation hasn't shifted from 38%. The data also tell us about those organizations that have been successful, for example, in reducing stress levels and keeping them at a low level. What that tells us is high levels of stress, poor health and well-being. That doesn't have to be the case within health and care organizations. We see examples of organizations that have raised engagement level and sustained them at a high level. Examples of organizations that are effectively dealing with discrimination. Most importantly, what we've been able to do is to link the data from the staff survey to national outcome data, patient satisfaction, care quality, mortality rates, infection rates, and the evidence is incontrovertible. The most important determinant of patient outcomes and patient satisfaction is how our staff are treated within our service. So when staff say there are too few staff, patients say there are too few nurses. They're not treated with the respect and the care and the dignity that they wish for. When staff report poor health and well-being, that's related subsequently to lower levels of care quality in organizations, significantly worse financial performance, and in the acute sector, to higher levels of patient mortality. So when you think about the data I talked about at the beginning in terms of levels of stress, it is so important that we don't see that simply as a byproduct of working in health and care, but an area of central concern for those who lead in our systems. The most significant determinant or predictor in our staff survey of the outcomes of healthcare organization work, be it mental health organizations, community care organizations, hospitals, ambulance services, is the measure of staff engagement. So it predicts financial performance, care quality, patient satisfaction, and we have some indications from those organizations that have been successful in raising levels of staff engagement and sustaining them at a high level about what are the factors that are associated with that. The first is that these are organizations that have generally developed a strong, compelling narrative, vision about what it is they're seeking to deliver for the people in their community. And their leaders live it. Secondly, what they've done is to retrain their leaders to adopt more positive, supportive leadership styles. So, for example, Nottinghamshire Healthcare there has a program called Invest to Lead, where they've retrained all of their managers and leaders to adopt more positive, supportive, compassionate leadership styles. Berkshire Health has retrained its 700 leaders in compassionate leadership. And third is that they have given staff the skills and the freedom and the resources to undertake quality improvement projects. Wrightington, Wigan and Lee is a hospital in the northwest of the country that has partnered with a private sector car parts distributor called Unipart and adapted the lean techniques that they use for use on the wards. So you see staff huddled around whiteboards on the wards every day, looking at real-time performance data so they can adjust their performance. And fourth is these are organizations that have built a high level of trust. We know from all of the research on engagement internationally that trust is the most significant determinant of people's engagement in their organizations. Their preparedness to bring their life experience to their work, their emotional intelligence, their compassion, their creativity, their courage. They do this when they feel they can trust their organizations. In our organizations, in the National Health Service in England, one of the key barometers of trust is levels of discrimination against groups that tend to be discriminated against. It's still the case that if you have skin my color in the National Health Service in England, you're 4 times less likely to be involved in disciplinary processes than if you have skin of a dark color. If you have skin of a dark color, you're 1.5 times less likely to be appointed from a selection panel. And the group that's most discriminated against is staff with disabilities. God forbid you should be a Muslim woman with a disability working in our health service. So trust is about the way that we create fairness and openness within our organizations. And also the 5th area is stability of senior leadership. So I went to Wrightington, Wigan and Lee not too long ago, this organization that has been really successful in raising levels of staff engagement and maintaining them at a high level. And they kept talking about the horse. So at their engagement committee meeting, and I asked about the horse, they told me the story of a patient, Sheila Marsh, who was sadly dying in the palliative care ward and had just hours left to live. And one of the staff asked her if there was anything they could do for her in her final hours. And she said, I would really love to see Bronwyn again. Turned out that Bronwyn was the horse she'd raised over a 25-year period because she worked at Haydock Park Racecourse nearby. So the staff got into a huddle, picked up the phone, called the family and said, can you bring Bronwyn in? So they arranged for a horse box, and Sheila Marsh was wheeled out onto her on her bed into the car park. And the horse clearly recognized her and nuzzled her and kissed her. And it was a really moving moment for Sheila Marsh, who sadly died a few hours later. It was actually also really moving and affirming for her family, who were really grateful for the staff taking this action. And actually it was really affirming and moving for the staff as well. Nobody called the health and safety department. Because there was a culture of engagement and compassion, staff did the right thing and they were supported. And our challenge is, how do we create cultures where staff will do the right thing in our organizations? And the final point in relation to the kind of the people management is, we know from so much research evidence the importance of positive emotion in human behavior. The more positive emotion we experience in our lives, the longer we live. If you induce positive emotion in a 3-year-old and give her paints to play with, she'll produce more creative paintings and play more altruistically with other 3-year-olds. And the same is true of 53-year-olds as well. If you induce positive emotion in a doctor, give her a bar of chocolate or something, she will make better medical diagnoses. The research evidence is clear. If you induce positive emotion in people and then subject them to the common cold virus, they're less likely to contract the virus. We thrive on positive emotion. So it's really important that as leaders in our organizations, in a context where there is so much negative emotion, fear, pain, anxiety, that we don't add unnecessarily to that by the way we lead, but that we seek to create positive, optimistic, appreciative, supportive environments. It doesn't mean turning up for work on a Monday morning in this kind of clown, comedic type character or personality. It means being authentic and open and expressing humility and being appreciative and compassionate in the way that we lead. But it also means making sure that we create the space for staff to talk about the negative experiences they have in the workplace, because those negative emotions are powerful and important. When a service user takes their own life, the staff in the mental health organization are devastated. When a neonate dies in intensive care, the staff are devastated. And we know that we need to give staff the space and time to validate, legitimate those sorts of negative emotions. We've been introducing across the NHS in England what are called Schwartz rounds. Some of you will be familiar with them. They're meetings where groups of staff come together over lunch, and a small group will discuss some negative experience in the workplace, not with a view to problem solving, but with a view to sharing emotional experiences, negative experiences usually at work. And the data we have, we know from our research on stress in the NHS that around 26.8% of our NHS staff suffer from debilitating levels of work stress that would have them categorized as suffering minor psychiatric morbidity, 26.8%. Those who regularly attend the Schwartz rounds, we've just finished the evaluation, are on about 12%. So it's really important that we create the spaces for people to be able to legitimate and validate the negative experiences they have at work. And it's also about making sure that we deal with those intimidating or aggressive behaviors, particularly among senior staff, that corrode the kind of cultures that we know are important for the delivery of high-quality care. If you have senior medical staff who are intimidating or aggressive, those behaviors are as dangerous to patient care as medication errors or dirty wards, because staff are afraid to challenge those behaviors. So as leadership communities, we must address those behaviors. How are you doing? You with me still? So these three areas, vision, clear goals at every level, great people management and leadership, are vital areas that we must focus on as leaders in our organizations. And the fourth, and it was the minister alluded to it, is the importance of innovation and quality improvement. We know that those organizations that are most successful in health and care are the organizations that have succeeded in creating cultures of innovation. Last year, we published a paper in the King's Fund based on a review of all of the literature on innovation, not just in healthcare, but particularly as it applied to healthcare, to identify those factors that we need to have in place to enable our organizations to be innovative. You can download that from the website. It identified the key elements that need to be in place. And I think in healthcare, we tend to focus very much on skills and capabilities, QI capabilities, systems and processes, and support for quality improvement, but tend to neglect some of the other areas, and I'll mention them briefly. But what emerged from that review was the fundamental importance of compassionate leadership to innovation. The compassionate leadership behaviors, attending, understanding, empathizing, and helping, are fundamental also to innovation. They create those behaviors seem to create the conditions that reinforce the fundamental altruism and intrinsic motivation of health and care staff. Where there's compassionate leadership, staff are much more likely to take risks within safe boundaries to try new and improved ways of doing things, like bringing Bronwyn into the hospital. Compassionate leadership creates what Amy Edmondson at Harvard calls the psychological safety in healthcare teams, where people feel safe to speak up about errors, concerns, problems, issues. And compassionate leadership encourages people to develop ideas for new and improved ways of doing things in the workplace and implement them. And importantly, compassionate leadership is associated with teams that are characterized by higher levels of cohesion and optimism and a sense of efficacy, precisely the conditions for innovation in teams, rather than fear and blame, which are precisely the worst conditions for innovation. But what also emerges from that review and research on innovation generally is the importance of autonomy. We conducted a review to look at cultures and climates of healthcare excellence all around the world, and we found that about the worst style of leadership that you could adopt is command and control leadership. For a workforce that is the most highly motivated, highly skilled in our countries, why would we adopt command and control hierarchical approaches to leadership? So it's about how we can create freedom from the bureaucracy, the rigidity, the hierarchies that characterize some of our health care organizations. So what we've been advocating is the importance of moving towards leadership being seen as a collective activity, away from leadership being about people in authority or leadership being about individual heroes, to leadership being a collective activity, where everyone sees that they have leadership responsibility. Like the very junior administrator I saw a couple of weeks ago presenting in a major London conference on their quality improvement initiatives. It's where there's shared leadership in teams. Although Lynn here may be the hierarchical leader, when Christina has the skills, the leadership naturally shifts. It's leaders working interdependently across boundaries, prioritizing patient care overall, not just their area of responsibility. And it's making sure that we've got consistent approaches to leadership within the organization. You know, what's your name?
Lawrence.
Lawrence. It's no good if Lawrence is here in one department, this warm, compassionate, supportive, positive, appreciative leader. He's nodding vigorously. He totally is, yeah? And then in the next department, you've got Christina, who is this despotic, demonic tyrant, you know? Do you know what I mean? We have to have consistent approaches to leadership in our organizations, characterized by authenticity and openness and humility and compassion and appreciativeness. And so our challenge is how we create that kind of collective leadership in our organizations to promote autonomy and to encourage support. But it's also, in the most innovative organizations, everyone's voice is heard. The voices of the people who dissent, the voices of the people who may be discriminated against, the voices of people in the community, not simply as token voices representing the community, but genuinely involved in the co-design of services for communities, genuinely involved in shaping the vision of the kind of healthcare systems that we want to create for our communities in the future. And it's about, of course, the importance of team working as well in our organizations. So we have abundant evidence of the importance of team working, and I'm not going to dwell on this particularly, other than to say, you know, when we think about the extent of team working in health and care in our system in the NHS in England, and we ask our staff, do you work in a team? 96% of them say they do. We're not quite sure what the other 4% do, but then we say, does your team have clear objectives? Do you meet regularly to review your performance, and do you work closely together, which we think are the defining characteristics of teamwork, yes? Clear objectives, meeting regularly to review performance, working interdependently. Then the figure drops to 40%. And what we find is, so we think 40% are working in something like real teams, and around 55–60% of people working in pseudo teams. If you look in the acute sector, the more people working in pseudo teams, the higher the levels of errors, stress, and injury. This group on the right are the people working in real teams. So we see a really clear relationship between quality of team working in healthcare environments, whether it's mental health or the acute sector, and errors, stress, and injuries that could harm patients or staff. When we look in the acute sector, we find a very strong relationship between quality of team working in hospitals and mortality. We estimate, using the most conservative estimates and taking account of other confounding factors, that if we could increase the percentage of people in our system working in real teams from 40% to 65%, that would be associated at a minimum with the prevention of 5,000 avoidable deaths annually. Teamworking, the quality of teamwork, is not just a nice to have. It's essential to the delivery of high quality care. So we need to make sure that our teams are working effectively. And what we've discovered from a research program we've been running for the last 25 years is it is a mistake to require our teams simply to spin the hamster wheel faster and faster. We began to ask the question of healthcare teams, what happens when you take time out from your busyness to review what it is you're trying to achieve, how you're going about it, what you need to change? We found, in whether we've looked at breast cancer care teams, primary health care teams, executive teams, community mental health teams, teams that take time out on a regular basis to review are much more productive and much more effective. A recent meta-analysis, and the research has been replicated around the world, a recent meta-analysis by Tannenbaum and Carasoli, based on accumulating the data from 49 separate published studies, showed that teams that do this are on average 25% more effective. Encouraging our team, we shouldn't just be encouraging teams to take time out to review, we should be requiring it. It's counterproductive not to. Make sense? So we need to be building effective team working and building dream teams in our organizations with inspiring visions and regular and useful team meetings. And making sure also that there are not chronic interpersonal conflicts in teams. They are simply a disaster for team effectiveness, and therefore will damage, in the case of healthcare delivery teams, the quality of care that's delivered to people in our communities. And it's also ensuring that in our teams, people are committed to inquiry, listening to each other, wanting to learn more from each other, rather than pushing their positions, and leading that inter-team working. I mentioned earlier, every team should have as one of its objectives improving the effectiveness with which we work with other teams in our organizations and outside them indeed. And it's about ensuring that we have team leaders who know how to lead their teams effectively. I'm not going to go through this. My mother strongly recommends that book on effective teamwork to you as a place to learn about team leadership. So how do we achieve all of this? The challenge that we recognized in our system was it's not enough just to advocate these kind of cultural values in organizations. We need to create them. And culture is about leadership, and that means we need the leadership that's committed to these values at every level of our systems, and that means creating effective leadership strategies. So we've designed a system to help every health and care organization in the world look at their existing culture and leadership, and then design a strategy to deliver the collective, compassionate leadership that's needed for them to be effective and to implement it. The principles were that we wanted to design a system that could be delivered internally, that would be evidence-based rather than fads and fashions and consultancy-based, and that would be open source, so it's available for you to download the materials. And it's delivered by an internal change team, and we have guidance on how you set that up. I'm not going to go through all of these. These are some of the tools that are up on the website to help you build team-based working, to help you develop cultures of innovation, to help ensure that you have an organization characterized by a commitment to vision and values, and where you have an approach to clarifying goals and ensuring effective performance. So those materials are all available on the website for you to use, and there's a community of practice as well. But I want to finish by going back to the beginning of what I was saying today, and that is that we have to ensure that we care for the people who deliver care in our communities, because it affects not just the quality of care, but of course their lives, their families, their well-being. So we need to build a sense of well-being by paying attention to some of the key factors that affect our well-being. Spending time with people we love and who love us, quality time with them. Exercise, of course. Being present, being here and now. Learning, growing, and helping others makes such a difference to who we are and to our quality of life. But most importantly, if you only take one message away from what I've been able to share with you today, it is the importance of compassionate leadership. I keep thinking, that if all of the people who work in health and care in British Columbia, probably 1 in 10, 1 in 15 of the population, come to work and encounter compassionate cultures, compassionate leadership, they take that out to their families and their communities. And if all of the people who use the services of health and care in British Columbia every year encounter compassionate care, they too take that back out into their families and their communities, and it spreads through processes of emotional contagion. The potential contribution of the health and care system to our society, above and beyond the delivery of health and care, is enormous. And it begins with the people in this room. So we have to model that compassion in our interactions. But in order to have the resilience and the capacity to be compassionate in our dealings with others, we first of all have to be self-compassionate. That means paying attention to ourselves, listening with fascination to ourselves, understanding the challenges we face in our lives and in our work, empathizing with ourselves, caring for ourselves, and then taking intelligent action to help ourselves in order that we can be who we can be and stay close to the core values that give our lives meaning, like courage, wisdom, humanity, justice, gratitude, and compassion, and enable us to have deeper and more authentic connections with all. Haitapka CM, thank you very much. Thank you. Thank you.